like to welcome everybody who's joined so far. My name is Margot Field and I have the pleasure of working for GP Supervisors Australia. So tonight we are putting together a fantastic webinar on what to teach a registrar about identifying and treating patients with a history of childhood trauma. A huge and important topic, and I'm very grateful to have our speakers. So I would like to welcome everybody here and just acknowledge that GPSA acknowledges the traditional owners of the land in which this meeting is taking place and pay respects to our elders, past, present and future. I'm not an Indigenous Australian. I was raised in Gadigal land of Sydney, but I now live in Wurundjeri land in Victoria. And I'd like to also especially welcome and acknowledge any Aboriginal and Torres Strait Islander people attending tonight. We really do commit to working together in the spirit of mutual understanding and respect for the benefit of the broader community and future generations. So thank you. Dr. Louise Stone might wave her hand. Hello, Louise. Welcome here tonight. Thank you for coming along.
Hello.
Louise is a GP in Canberra and a medical educator with clinical teaching, research and policy interests in mental health. She's provided mental health courses across Australia, face-to-face and online. And she has been a senior medical advisor for the AGPT training program from 2007 and to 2017. So welcome and thank you for your deep experience that you're bringing to this tonight and your interest and commitment to GP supervisors. I'd also like to introduce Dr. May Su. May is a GP and a supervisor in Glebe in Sydney. She's also an examiner for the RACGP. She has a Master's in Mental Health from the New South Wales Institute of Psychiatry and has been appointed to the role of a specialist lead in that organisation. May clinically sees the breadth of general practice but has a special interest in mental health. And I think you'll find with these two fantastic women tonight, there is a breadth of knowledge between the two of them that's really practical. So thank you, both of you, for bringing your skills to the webinar tonight and welcome to everybody who's joining in. Thank you.
Thank you very much, Margot. I really want to thank everyone who has made it tonight, and we were really impressed by how many of you are able to actually make it tonight. I think that shows just how important a topic that it is that we are going to be talking about today. We want to thank GPSA for having us, particularly Nicole Higgins, who really advocated for this important topic after we published. So you can read the article, Adult Survivors of Childhood Trauma, Complex Care, Complex Needs, which is been published in the Australian Journal of General Practice. And we've included the article in the references at the end of today's talk with a link as a helpful guide for everything that we're going to be talking about. So it may be helpful as a bit of a refresher after we've covered what we're going to be talking about. So, I thank Margot for the introduction. As you know, both of us are GPs and really passionate with general practice and everything it brings, including psychological care. We both teach GP registrars and we both deliver GP MHSC level 1 and level 2 skills training. So we know we've only got about an hour, and by no means are we going to cover everything that you need to know about managing childhood trauma. But hopefully we're going to be able to discuss in the group how to facilitate a registrar developing skills and managing a person who presents with a background of childhood trauma, including common presentation, pathophysiology, and an overview of management and self-care. So we know 1 in 8 people who present in general practice have experienced trauma. It's pretty common. The 2016 Australian Bureau of Statistics Personal Safety Survey estimates that about 2.5 million Australian adults, so 13% of the Australian population, experience physical or sexual trauma during childhood. We're less clear on the rates of neglect or physical or emotional abuse in general practice populations. And bear in mind, this is likely an underestimation of true prevalence because it's obtained from proxy data from Child Protection Services, so it doesn't include incidences where it hasn't been reported to authorities. There have been some studies that have looked at one or two abuse types in general practice, and most of these estimate the rates between 5 to 10% overall, with the incidence being higher in women. So some of the studies in Australia estimate the rates of sexual abuse, because I guess that's where a lot more of the studies have occurred, up to 1/6 of men and 1/3 of women. That's 1 in 3 women that we might be seeing in our rooms. And just consider, when you're practicing in medicine in your rooms, would you have 1 in 3 women disclose to you or your registrar that they've experienced childhood trauma? It's common, but we're probably not having the practical experience that we get these direct disclosures of childhood trauma. And it's probably even less the case for our registrars. So for the people that you see, you might actually be seeing a higher prevalence than what's actually presenting. And one of the challenges we find for many general practitioners is what to do when someone discloses and the distress associated with this. It can be even more challenging for those of us who are junior doctors or registrars. Recently, the World Health Organization, in the new ICD-11, has ratified the diagnosis of complex PTSD. This diagrammatic representation is a helpful way of considering the common presentation and associated management of complex PTSD when adult survivor of childhood trauma. So it's coming. An understanding of why a person with complex trauma presents in this way can be understood with principles of neurobiology, attachment theory, and family systems theory. We understand that healthy attachment, particularly in early childhood, is important for the healthy development of neural tissue. However, the experience of stress and heightened distress can result in neural atrophy, particularly in the section of the brain which connects the thinking part of the brain with the more primitive emotional side of the brain. And that's the bit which influences emotional regulation and problem solving. So if we can think about it this way, a person who's experienced trauma may have a very different brain from someone who hasn't. In addition to the biological mechanisms of brain tissue, attachment also demonstrates for the person what's a healthy way of interacting, a healthy relationship. And families are made up of more than one relationship sometimes, and how those relationships work together can work or not work. We recognise, regardless of how they work, people growing up in those systems can get used to and tolerate them. And this can reinforce unhelpful family systems. So that's family systems theory. Intergenerational trauma can occur when unhelpful patterns perpetuate down the generations. So going back to neurobiology, stressful situations can also impact on the ability to concentrate and remember things.
So it's Louise here, and I just wanted to say it's wonderful to see you all. Not that I can because we're over Zoom, but I know how tricky it can be to teach this sort of thing in general practice. And this is something that I use with registrars to try and give them a sense of what's gone on. And this idea that if we bring a child or the adult reflecting back on their childhood, that they carry a number of things in their backpack. And I like to think of these things as both positive and negative. So the negative ones, of course, and particularly we had some questions that came up before this presentation, and they were asking questions specifically about our Aboriginal and Torres Strait Islander patients. And those patients, of course, have significant intergenerational trauma. We know that there are some genetic changes. We know that there is some epigenetic modifications that occur down the line when you have trauma that's intergenerational. We also know, as May said, that it encourages learning patterns. So the children of alcoholics who need to who can then become married to an alcoholic, for instance, and you get these perpetuations of learned behaviours. But we also think that there is a much more, I suppose, neurobiological link in the trauma that comes from ancestors. Of course, parents who've experienced trauma of their own standing can then parent in a different way that then contributes to the child's trauma. So it's quite helpful to think about that. So next slide, May. So we wanted to introduce you to this model, which you've probably seen, which is our Aboriginal colleagues on behalf of the Australian Indigenous Psychologists Association and their model of holistic care. And this is looking at emotional and social wellbeing and this concept of connection. So the way that connection to family, connection to community, but also connection to self. And as May said, one of the biggest fractures that occurs with childhood trauma is a fracture in the sense of self. This belief that coming through that you don't have the right to breathe the same oxygen, that you have no validity, that you have no right to be in the world at all because you are worthless and hopeless. That sort of brainwashing that occurs with emotional abuse, and let's face it, a child who experiences physical abuse and sexual abuse must experience emotional abuse by definition. Growing up with that sense of self being shattered means that connection to self is shattered. And that's one of the reasons why we see the adult survivors of childhood trauma struggle to be in the world. So for our Aboriginal patients, this is a good model. In answer to, will you get copies of the slides? You're very welcome to our slides. You're very welcome to the talk. And we've summarised it all very helpfully in a 1,500-word document for you in the Journal of General Practice so that it's all nicely spread out and you can hand it to your registrars if you please.
So I know Louise has talked about this in terms of how they all fit together, and I think we need to consider that these underlying processes help to underpin the presentation of emotional distress that we see with a person in complex PTSD. The previous slide looked at it from the lens of social and emotional wellbeing, which is a construct which is really helpful to articulate what's happening in Aboriginal and Torres Strait Islanders. But I think just for the purposes of today, we'll also be using this. But I think it's helpful to be considering that in different groups there are different aspects which might be occurring as well. I think we also need to consider that for a person who presents in this way, they may also be getting a raft of lots of other diagnoses. If people are just looking at one segment at a time. For example, if they're mostly presenting with the re-experiencing and the hypervigilance, that might mimic paranoia or psychotic break. The somatic symptom disorder may mimic a raft of medical diagnoses. We might consider unexplained medical illness, or they might be responding in unanticipated ways for what we consider understandable medical conditions. Avoidance can present with eating disorders, substance abuse, gambling. Not understanding the story beneath, so I think about this as the bottom of the wheel, of emotional dysregulation, interpersonal instability, altered belief systems and impaired concentration and attention, inhibits our ability to appropriately interact and understand the interpersonal dynamics within and outside of consultation. So these people get so many different diagnoses without having a unifying understanding of what's happening to them. This inhibits us appropriately managing the whole person in their presentation. Understanding then how they're presenting in a unifying diagnosis helps us understand why a person does present in the way that they do. And it also helps us understand why comorbidity is more prevalent in this group of individuals. I found a really staggering statistic when I was looking at some of the prevalence data when I was looking at this talk, and this is again from the Australian Bureau of Statistics, but they looked at, from a health perspective, 3 conditions directly linked to child abuse and neglect: anxiety disorders, depressive disorders, and suicide and self-inflicted injuries were estimated to have been responsible for 0.5% of all death and 2.2% of the burden of disease and injury in 2015. So that's a whole of statistics. But when they looked at that, so more specifically, it's estimated that there would have been 26% less suicide and self-inflicted injuries, 20% less depressive disorders, and 27% less anxiety disorders in 2015 if no one in Australia had ever experienced child abuse and neglect during childhood. That's just staggering. I think that can also be quite demoralising when we think of those statistics, but I think what's probably also really important for us to recognise is that if we actually can treat survivors of trauma, that we can actually intervene in that cycle of intergenerational trauma that otherwise might arise. Treatment should be individualised, and by understanding which process is predominant when a survivor of complex PTSD presents, this helps us target more effective management options. And in 2013, the National Mental Health Commission described and supported a fundamental shift in approach to mental health care within Australia, which is recovery-orientated practice. This empowers the person's capacity within their recovery journey, which is a really different principle historically from some of the training which we've been exposed to regarding mental health care, particularly important in this group of people where they've already had a fractured sense of self and disempowerment. So how do we empower a person in recovery? Well, some people who have experienced childhood trauma can recover through their own resilience. And in fact, the experiences that they've had and learning how to overcome them and finding their own strengths can be a really powerful tool for recovery. So that helps to underpin the theory behind what we're doing. I think we also need to consider what is the model with what we're actually working with at the moment. And essentially what we often offer to people is medication or DBT, like dialectical behaviour therapy, which is reasonable if we're targeting this just to the issue that the person's presenting with. Essentially, all experienced therapists work in a team for the management of complex cases, because this makes managing the interpersonal challenges that can arise and manage and prioritise symptoms based on the presentation at the time with the end goal to address those issues work more smoothly. How they do so might be with a combination of medication and or psychotherapy. We have to bear in mind that the medication is just an adjunct to distress tolerance in this situation, and the mainstay of therapy is in the psychotherapy. I noticed Michael Fash's point as well about asking what has happened to the child well before asking what is wrong with the child. And I think that underpins all of what we're doing, is having an understanding of why it's occurring helps us understand what we're going to do moving forward. So if we think about psychotherapy, the framework of how we actually implement this differs with each approach. But if you look at studies which look at different types of psychotherapy, the end goals and what they look to address is actually all the same. It's just the construct which changes. So an example of this is psychodynamic psychotherapy that looks at this, looking at transference and counter-transference within the relationship. You know, how the patient feels about the doctor, how the doctor feels about the patient, and examining that and exploring that helps the dyad come to an understanding about processes and patterns which are occurring. If you're looking at this in terms of a dialectical behaviour therapy model, it looks at it from a cognitive and behavioural approach. More commonly in general practice, we use supportive and cognitive behavioural approaches. So that's what we're going to stick to today. And the important thing to remember is that the construct must make sense to the person who's undergoing therapy. And it's best to stick with one framework for therapy to avoid confusion while the person's undergoing therapy.
So I just wanted to give you a bit of an example of the sorts of things that might turn up. And I've been reading the chat, so I'll come back to some of your questions in a minute. and just explain what might happen to someone like Sandra, 45-year-old woman with a history of rheumatoid. She's in the middle of a divorce. She's a teacher. She's married to an alcoholic lawyer, which is really tricky. And she's got 3 kids. All 3 kids have got challenges. She's got a couple of autoimmune diseases, high prevalence of somatic distress in these people with anxiety and depression. And she's an ex-smoker and a social drinker. She's got a history of domestic violence, and there's no history of trauma in the notes. Now, there's a few things that I just wanted to say, and I thought it might be helpful at this point to sort of hear what I might say to Sandra. Assuming, of course, that Sandra has discussed or revealed her childhood trauma to me in some way. And the question I ask, just so you know, often is, what were you like as a child? And the reason I ask, what were you like as a child, is because a number of people who've experienced childhood trauma will not believe that their experience was traumatic. What they will believe is that they were bad children. The sorts of things I get back are, well, my mother says I was born evil. My mother says she should have aborted me because I was such an awful child. Oh, I don't know how my parents put up with me. I was just dreadful. I was just an awful human being. And, you know, I deserved what I got. So that's the normal sorts of things that you will hear that give you a bit of an inkling that maybe childhood wasn't good. And if you're trying to work it out, I ask the question, was your childhood was there a safe and secure place in your childhood? Was your home safe and secure? And these people will say very quickly, absolutely not. And that gives you the clue. You don't have to know exactly what happened. You don't have to explore exactly what happened. That will usually give you enough to know that it wasn't great. Someone like Sandra with somatic concerns, you usually have to put in some sort of explanation. And the way I do it is to say exactly what May said about brains, that brains are fundamentally changed with the experience of trauma and neglect. And the brain doesn't end at the neck. So the nerves go all the way down to the toes, and that means that they can influence all sorts of things. And when you flood someone with stress hormones, and I'm talking the way I would talk to a patient, then what you get is someone on high alert during childhood. And when they're on high alert, they don't remember things very well, so there's often no memory, which means they don't understand why they're getting triggered because they don't remember what the triggers are. So their experience is they're having panic attacks, or what they see as panic attacks, and affect dysregulation all over the shop, and it makes absolutely no sense. If they're women, they usually get diagnosed at some stage with borderline personality disorder. They often get diagnosed with substance abuse because that's their way of coping with affect dysregulation. And as May said, sometimes their re-experiencing is interpreted as some sort of psychosis. So they often have acquired this raft of diagnoses. But the thing that you will notice most of all is that little purple segment. This woman, if she has a history of significant or repeated childhood trauma, she will believe there will be this feeling of being not worth the oxygen. She doesn't deserve to breathe the oxygen in the room. She's a waste of space. She has no validity as a person. That will give you much more of a picture. But as you can see, what you usually get is this constellation. Now, remember, as GPs, our job is not to fix all this mess, but we are the storytellers of the world. One of the things that we really try to do is to construct some sort of narrative repair. One of the authors I love talks about the shipwreck of someone's narrative, that they have this idea that their life is heading in a certain way and then it is blown apart by trauma and suddenly they don't know where they're going, they don't have a map, they're just lost in their narrative. The way of describing complex PTSD as a concept actually helps them to understand that they, just as Michael Fasher said, they have had their story disrupted. They are not wrong, okay? And that's what's really important about this system. And it's not about telling people, it's about being the GP. We had a comment about, it's Arthur Frank, Pam, Arthur Frank wrote the stories about the narrative shipwreck of disease, and Arthur Kleinman are the two people. But the thing that I think is really important is helping people as they move towards their recovery to start to describe themselves, rather than as a helpless waste of space, as being somebody who has experienced a lot of difficulty and has survived and has had agency, and there have been things in their life. So yes, any of the medically unexplained symptoms are much more common in this group. So is anything neurological like migraine. So is autoimmune disease in this cluster. We were asked about reparenting. Can I say the bit that matters? Reparenting does not mean having no boundaries and basically being overly sympathetic and taking the person under your wing and over looking after them. We'll talk about this with respect to registrars. Reparenting is about demonstrating what unconditional positive regard looks like. All babies have a right to unconditional positive regard, that no matter what they do or say as toddlers, that they will still be loved. Even if you make mistakes as a parent, you'll still say, you know, I love you, darling, but I don't want you to hit your brother. You know, it's that sort of idea that you will still be loved even if you make mistakes. These guys have not had that. And so us demonstrating that regard is very, very important. And that's the core concept of reparenting. Unfortunately, some people take it too far and become, you know, over help, and that's a different scenario.
Louise, I'm probably going to comment to that I think just like with parents, it's also important when there are splits which occur in the interaction, or just like teenagers, you know, part of teenagehood is at some point trying to establish independence and working out how that goes. And as part of a good therapeutic interaction, it's about how you work those processes out and work out how to do that in more adaptive mechanisms. And at some point, you do want the person to be able to leave the nest. So that's the ultimate goal.
I think that's a very interesting question, Dimity. And welcome, Timothy. It's lovely to see you. The answer is not necessarily. People don't necessarily need to know the link between their fibromyalgia and their complex trauma. The thing that's most unhelpful in medically unexplained symptoms in this group is to get into an argument of whether it's in their head or it's in their nerves. You know, you get into this sort of tug of war with the patient thinking the whole problem is in their body and you suggesting it's in their head, and that's just incredibly unhelpful. So I use the word stress because it seems to be a positive. People don't mind admitting to being stressed. And I talk about things like alcohol, sleep, diet, exercise, stress, so that it's all meshed in together and there's no separation between mind and body, because there shouldn't be. I do say to people that when children are stressed throughout childhood, that it upregulates their nervous system. So their nervous system becomes on high alert because their nervous system is trying to protect them to a constant set of threats. So I say they change from a lion into a deer. You know, deer are terrified of absolutely everything because absolutely everything can kill them, you know, and in kids who've been under constant threat, that's what they're like. They're scanning the environment all the time, waiting for the next, you know, threat to come around the horizon. So those sort of people, they upregulate their nervous system. It's not uncommon for them to present with sensory stuff of not coping with loud noise, not coping with lots of lights, not coping with lots of complexity. And, you know, we could get started on the link in, you know, there's all sorts of other links in that as well, but they also have a higher experience of chronic pain. So it's very common for that crossover of childhood sexual abuse and chronic undiagnosable pelvic pain, for instance. That metaphor goes on there, why it's pelvic, and it's quite confusing, but basically they have an upregulated nervous system. So we wanted to move on, and we'll go to the next slide, I think now, May, and keep moving and have a look at, well, what does this mean in terms of the way that you guys are actually going to teach this stuff and manage this stuff. And May, I wanted to hand to you for a second. There was a question in the chat that said, what about us? Because obviously 1 in 3 of us is a survivor of childhood trauma. That's just the way it is. Does that mean, and people ask me this all the time, does that mean that we if we have that experience, that we shouldn't be doing this work, that we should be doing this work, that we should be careful doing this work? What does it mean to have that crossover? So I might just get you to comment on that, May.
Yeah, look, I think it's a good question, because I think just like anything, like I think the reason that often that we are attracted to this work may be that some of us may have our own experiences as well, and that may be the same case for our registrars or for ourselves as well. So I think traditional models of being a survivor are often very purgatory. Like, it's often this consideration that everyone is going to end up with this as a borderline patient if they've experienced complex trauma. And I think there's also the reminder that some people have different experiences that occur, and you may have different manifestations of any of this symptomatology that we mentioned that may occur for someone who's experienced complex trauma. And that's the same for our patients, and that's the same for any of us who may have experienced any of those things as well. I think what we also do know is that by experiencing challenges, that survivors also can have more empathy about what's occurring. And so you may actually find that, just like anything, that it may also bring more depth and emotion and understanding to what you bring to clinical practice. But I think it also does mean that you also just need to be mindful about the fact that, just like anything that we see in general practice, that sometimes seeing challenging things also can be triggering and traumatizing as well. So we need to be mindful of that balance when we're actually managing this. So I think this does come into, I think, the greater issue about why we also do find looking after people with complex trauma challenging. And part of it is about doctor factors, part of it's patient factors, as we've just talked about, but part of it is actually about issues within ourselves. And part of it might be our own experiences and triggers which are coming on. Part of it may be that, regardless of our own experiences, it may be that, we're also trained to fix things, and we're trained to make people get better. And I think seeing people where it isn't obviously smooth is a really hard thing to sit with as a doctor as well. So it is really incredibly uncomfortable sitting with uncertainty. It's uncomfortable for the patient, but it's also really uncomfortable for the doctor as well. And so I think being conscious about that's a really important step. And I think we also need to realise what happens when that is happening, that in most situations, either or both of them, the patient or doctor will try to conceptualise an explanatory model as to fit what's happening, even if it doesn't really fit. And if that's in conflict, it can affect the therapeutic alliance and relationship, like the example of the fibromyalgia and the complex trauma. It might be that each of the people in the room has a different understanding of what's going on, but you need to then come together about how you're going to work together with that. You may not have exactly a shared understanding of that, but you need to have some common ground that you're going to work on, that then you can move together with it. And I think Louise's example of stress is a good example, or sometimes even if they're not understanding that the stress might have been an antecedent to why they're presenting, a recognition that just being in chronic pain can then cause stress in itself. And so dealing with that is going to help their recovery of whatever other issues are going as well. So you don't have to come to a full shared understanding, but you do need some sort of working model that's going to work together.
I just noticed Michael Fasher's comment, which I think is really important, that May said this earlier, that not everybody who's experienced childhood trauma becomes, someone with borderline personality disorder and the entire circle of issues, that there are protective factors. And, if we look at that little model that we introduced earlier from our Aboriginal colleagues, connection to community, connection to spirit, connection to family, if there's a grandma in there that is loving and caring, often that will mitigate a lot of the risk of the child experiencing issues as they move into adulthood. So, it is very variable how people express their trauma in adulthood, and depends a lot on whether or not there's been restorative options as children, whether or not. And that makes sense. I mean, if we look at some large population situations, the children who were evacuated, for instance, in World War II, otherwise we would have that entire generation who were all severely affected by basically being abandoned by their families for good reasons, but nevertheless being abandoned. Can I say one of the ways that patients get hiccups is that patients often don't like to see their parents as being traumatising. And you get into this whole discussion about, but mum and dad were doing the best they could. Can I just share with you something that I say with those people? I think it's really unhelpful to have a culture of blame against the parents yourself. What matters is the impact on the person in front of you. And I always give the example of a child with leukemia. Because a child under 5 with leukemia, their experience of the world is that our adults that they know and trust, no matter how well it's explained, hold them down and put them in hospital and do awful things and don't listen when they tell them to stop. And everybody has the best interests of the child in their minds and hearts and want to do the best for that child. But the reality for the child's lived experience is that they have this history of trauma. And we've all seen adults who've had a childhood severe illness, who've grown up with anxiety. You can talk about the trauma in the parent's life, but also it's not, I often also use the example of rickets. If mum and dad live in poverty, it's not their fault that the child ends up with rickets. It's the parents have done the best that they can with what they have. And that's sometimes just like the push-pull thing you get with medically unexplained symptoms, where you can get you as the doctor saying, I think it's your depression that's the problem, and then saying, no, I've got some awful physical disease, and it's like a tug of war. You can also get into this tug of war if you're not careful with I think, this what's happening is coming from some sort of childhood trauma, and then saying, but mum and dad loved me, they really did, and they didn't mean it, so therefore it wasn't traumatising, So you've got to find a model that you can explain that keeps those two things in balance so that we can work with it. We've got some common ground. But parents don't have to be presented as the devil incarnate. The parents are often doing the very, very best that they can, and no parent is perfect. So I think trying to hold those together is really important. And you guys, you are the storytellers. This is what you do. Even if you don't fix anything, as May said, if you could try and get a story that the patient can hold that is less awful than it's all my fault, I was born evil and no wonder I was, sexually assaulted because I was just a dirty, horrible person. If we can get a better story than that, we've made a really good step in the right direction. And Claire, we have moved on from the schizophrenic mother, thank goodness. It's still out there, of course. Mothers are always to blame for most things, but at least I can say that as a mother, I'm allowed, but at least we can, keep those things in sympathy, unless, of course, the patient comes in and tells you about their awful, dreadful person and they've already made that leap, which is very different.
Yeah. I think we also need to bear in mind that, just like anything, any person comes as a mixed bag. And so I think that helps to hold things for the person that I think sometimes when people have had challenging experiences, they may see things very black and white, that, they've had experiences which were adverse, but it means that they can't necessarily see the positive experiences that they have had. even if they have occurred from the same person. And I think part of that is coming to an acceptance of all of the experience which has occurred, those which haven't been positive, but also those that have been positive, and bringing that all together. It's not and there's a kind of I guess that's why we call it dialectical behaviour therapy. There's a dialectical nature of that, where you can see things where they can be both good and bad, which are happening at the same time. And the reason why that's so important is because you can have these really mixed feelings for really important figures in our lives. And so coming to terms with that is actually a really important process. And I think, exactly as Claire said, I think we are moving on in terms of everybody is bad, but I think there has to be some process of understanding, particularly where for some people they can be very black and white in certain ways. So we need to have some sort of process to actually move people to a more robust understanding of what's actually going on. I really like Dimity's example about, I'm just going to read it out, which is a doctor patient whose parents were Jewish survivors of the Holocaust, started to see every patient as someone who was going to die. He understood about the genetic influences, but it didn't help. And I think it is one of those things where, I think people can be really understanding and they can know, but it doesn't help some of those almost really visceral reactions which they get in response to the experiences that they've had.
It's weird, when I started training, I thought that insight built everything. Once you understood what was going on, it was all fixed. It's silly, really, that we believe that. I mean, we don't turn around and say, look, you've got a broken leg. There, I've solved your problem, off you go. We actually fix the leg. But somehow in psychotherapy, there's this idea that as soon as they get insight, everyone's going to go, aha, wow, that solves the problem, and walk away cured. It doesn't work. And I think that one of the things we offer as GPs is that drip, 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 drip of seeing a person and treating with them with respect over and over and over and over, until some of that respect starts to inch into being self-respect. That's the work. That's where the work sits. It's not what comes out of your mouth as much as the environment that you create in that room of taking this person seriously. It may be the first person who's done that. Can we move on to the registrar bit? But I was just thinking we're moving towards the end of the session, and I just want to make sure that
So I did want to probably just share this slide though as well, quickly as well, just as and maybe you can have a look at this in your own time, and it's in the article, but just to have a chance to look at that, because this can help break down if there are difficulties within the consultation itself and communication, about how to just break down if someone's having difficulty in terms of being able to communicate what's going on, and trying to break that down and then work out where you're going to go with that. So we'll go on to the registrar difficulties. Was it this one?
Yeah. So we wanted to talk a little bit about how the registrars get into trouble, because the registrars do get into trouble. And I just thought everyone might be able to just type one of the things that registrars struggle with these patients. So, what are some of the things? Where do your registrars get into trouble? Anyone's welcome. Yep. Getting over-involved. Yep. Sympathising, not empathising. Giving too much. Yeah, it's interesting. And the other side of being judgmental and not giving enough. Yes, absolutely. Not realising somatic symptoms, yes. Going on, my job is to fix it. Yeah, fix. Oh, I do that. I know.
The over-prescribing, yes, you see some of those, just easier just to make that script, so yes.
Yeah, and of
not
course,
just the registrars who get into trouble, yes.
Absolutely. Yep, absolutely.
Oh, we've all been, and I think I empathise with the person being too upfront. I think sometimes it's being careful about, there's a tricky balance, I think, sometimes, because I think a lot of the literature in terms of this area is from psychologists or psychiatrists, which is very much a hands-off approach. But it is a little bit counter to what happens in general practice. So I think finding that boundary can be a tricky thing, I think, particularly in general practice as well, about how much to share. So
yeah, Martina, setting the need to set boundaries. I always say, getting the empathy between apathy and sympathy. You know, the apathetic ones are bad because they don't care. The sympathetic ones drown. So it's trying to keep one foot on hard ground and one foot trying to reach out. So let's just give the first lot, May, and let's talk a little bit. This is some of the things that people have raised in workshops that we've done. So there's an organisational stuff, you know, time. I was reflecting, I came from the family medicine program, this is how old I am, and we were always taught that catharsis was great, we just needed to help the patient cry, but they never said anything about structure. So, you know, my generation just tried to try and care and care and care. And you can do that all day and drown. You can see one patient for 6 hours and it wouldn't help. I did want to raise the issue of gender because we know that abuse often occurs at the hands of men. And what that means is that traumatised people will often select young female doctors. And we find that some of the young female doctors really struggle with imposter syndrome stuff because they say, why is it my colleague seems to be able to keep to time and I'm hopeless with my time management and I don't seem to be able to manage things? And my favourite phrase, which I developed over many years, is I don't have a time management problem. I have a complexity allocation problem. I just get all the hard ones, and that's why I seem to take, I mean, maybe it's just my excuse, but anyway. And I know that there are female relatives, I know it's not universal, but certainly when you're getting things like sexual abuse, you will often, and you will also have this sociological thing that I wish wasn't the case because, you know, I've spent a lot of time and have a lot of respect, of course, for my male colleagues, but there's something about the community beliefs about a lady doctor in certain environments that somehow a lady doctor will be more empathic, will be more psychologically minded, those sorts of things. Doesn't mean it's true, but it's this sort of cultural, social expectation in many communities. So I think it's often the young female doctors do drown. Maybe not putting things together. You know, if you use the old models where you just get people to tick a box, then what you're going to find is you'll label everyone with depression. Not knowing how to ask the questions, not sitting with distress, registrars having unrealistic expectations of what a successful consultation looks like, not tolerating the fact that sometimes you get it wrong and that those ruptures and repairs that you do are actually quite helpful. There's patients that you don't like, and registrars find that a bit shameful that there are patients that they don't like. And diagnostic overshadowing, once they diagnose them with depression, everything's due to their depression and they don't look further. So the other thing is, and that's the next bit, May, is the issues of self-care and this idea of transference and counter-transference. And I heard a really good explanation of transference, which was, who am I in the presence of this person? And if I become a person who is angry and dismissive in the presence of this patient, then I'm probably not a great doctor for them. We need to be aware that, you know, some 1 in 3 maybe, who knows, of doctors are going to find some things triggering. And I will say, when I worked in a small country town as the only female doctor within 3 hours, you know, it's just a reality that vicarious trauma is going to happen. I spent a lot of time with traumatised people. And what then happens is that, you know, I really couldn't see a perpetrator. I just couldn't do it. I didn't do a good job because I was flooded, and that was what vicarious trauma did. I think self-care, trying to help registrars not fall for that rescuer idea, that they're there to rescue the patient. With boundaries, I talked to one of my daughters for an analogy about this, and the thing that I always use with registrars is it's a bit like a whirlpool. If you're a really strong swimmer and you're really sort of competent and senior, then you can go a long way into quite dangerous waters with some patients. But if you're a registrar and you're just learning to swim, that's not really all that safe. And it's helping registrars know when they're starting to get a bit too close. And I think that's really important. I do think that there's some siloing of people who say, I just don't do depression, and that's a bit sad. And this concept of burnout, and, you know, that's a big problem. So the question is, how do you then turn that into something else? And I want to flick that back to you and say, what stops you guys burning out? Because I'm aware, I'm 55, I don't care about saying that. There's plenty of you in the room who are older than me. Why are you still here? What keeps you going despite all this? Being a supervisor is hard. You know, remediation registrars constantly, taking registrars constantly is hard. Managing these patients is hard, and yet you are still here. And the question is, what do you do in order to make that so? Because that's the bits the registrar probably doesn't know yet. And I'll be interested if anyone wants to put something up in chat about what they do to keep themselves safe. Vicarious resilience is the idea that you can pick up skills and strategies from your patients and you can just absorb them, but you can also consciously note them and pass them on. I think most of the wisdom I've acquired in practice has got nothing to do with theory. It's been, you know, the wisdom acquired through listening to an awful lot of people.
Yeah, I think there is a lot where sometimes we do get that coping with horrific things and surviving and coping and moving on. But I think the only tricky thing, it's like putting the frog in boiling water, and if you immediately put it in boiling water, it jumps out. But if you've got the frog and you build up the heat bit by bit, people adapt to a ridiculous amount sometimes of really stressful situations. And I think just like that can happen for our patients, I think we also have to be mindful that can happen for ourselves as well.
So if we go to the next slide, I think there's a few things that people have raised, and, you know, we've talked about very different strategies. I'll hand over to you for this slide, but before I do, I just wanted to throw out there my personal experience, and I find sharing with this to registrars is often quite liberating for them to be very upfront with, look, I've had a clinical supervisor, psychiatrist do, psychologist do, that's been my solution and I've done that for 30 years. And they always look shocked that I would be prepared to say that I'd be prepared to say, look, you know, found a good psychologist who knows a lot about trauma. She taught me a lot. I put that together with some readings that she gave me and, you know, and debriefing about patients, and sometimes with her telling me that I needed to slow down, and that was my mechanism. And just making that clear to registrars gives them permission to then seek their own supports. So I'll hand back to you for this slide, May.
Yeah, and I just also wanted to feedback. I'm loving all of the comments which came up about what people are doing for their own resilience as well, because bear in mind as supervisors that modelling that actually that this is an important thing. I mean, it's why we continue being supervisors, you know. Hopefully we have our own strategies so that we haven't burnt out ourselves, and considering why that's the case and what we've been able to put in place to implement that is also really important for us to share also with our registrars as well, just as much as the clinical skills as that we teach them. So I think it's sometimes helpful for us to consider what might be occurring within the consultation, considering the therapeutic alliance. How do we cope when we don't know what's going on? So maybe for especially some of those junior registrars, working out processes for how they learn, how they develop information, and how do they work out when there isn't an answer for what's going on, and how do you communicate that with the patient and feel okay about not knowing when they feel like they should be the expert. Organisational aspects like do you have enough time, appointment scheduling, which might also help with getting out the kind of demographic of what they want to see as well, and considering components of conversation of the consultation. I think there is, as Louise was saying, you know, you can be empathic, but I think you also need to also work out how to actually structure a consultation so you can get the information out, which I think is why we shared that slide before about how to effectively actually move forward but still be caring as well. In regards to outside of the actual consultation as well, a few of you have mentioned like ballot groups and supports, which Louise and I just can't empathise enough how important that is. And outside of work, also making sure that there's time for relaxations and de-stressing. One thing I would comment, and we haven't really talked about this, is that bearing in mind that a lot of the patients that we see with complexity often may present with avoidance as a coping mechanism. And I think as clinicians, that can be really stressful if that's what we're actually seeing. So bearing in mind that, being conscious that that is a kind of a primitive coping mechanism under stress, and that it might actually be occurring, and learning how to cope with that may also be an important process, particularly when your own coping mechanism might be quite different as well. So if you're working with other people, other team members, having different team members have different coping mechanisms may also be something to come to terms with as well. And there are practitioner-specific supports as well, which we've included there. So I thought one thing that I have been asked by registrars is, how does it fit with exams? Well, you know, at my job at Helly, we cross-reference both curriculum. I've just put up the RACGP ones up, but I think you'll agree the ACRON ones have similar chapters. But I think you'll agree that the approach to adult survivors of complex trauma covers all of these domains. You know, it synthesises all the knowledge registrars have and will continue to accumulate, and challenges our own professional knowledge and professional and ethical role, and it requires a really deep understanding of usual patterns of illness. I think that's why it's an area which is often really seen as challenging. But I think we need to be frank. Complexity in adult survivors of trauma is unavoidable. It's general practice bread and butter. It's what we do. And in medicine, our job is mainly to look after people in times of crisis, illness, suffering, and death. It does mean that sometimes when people are suffering, they don't behave in ways that would enhance the communication or therapeutic relationship. And understanding this, learning skills to manage and improve communication and relationship helps both you and the patient in the overall care, and also improves subsequent interactions. We have to remember, just like our patients, we're people too, and we can't look after people well if we're not looking after ourselves. And it's reasonable to know and abide by what things keep us well. So we may not have all the answers, but having a supportive GP along the way and to empathise with the frustration of not having the answers is sometimes enough. And those relationships and journey is what makes GPs really valuable.
I just want to close our talk by thanking you all for what you do. I know that being a supervisor is challenging, rewarding, wonderful, but draining, and, you're constantly juggling a lot of balls in the air, and this is an example of some of the difficult work that you do. And if it wasn't for you, training would be, I don't even know that there would be training, honestly. I think supervisors are the absolute core. So we've come to the end. We've got a last slide there that just shows some references, which you might want. Our paper's at the top there because, that's us, but also because it basically goes through everything that we've talked about tonight, so that hopefully it gives you a nice summary and explains things in a little more depth. And then there's a couple of things down the bottom there that you might be interested in. But we really want to thank you for the work that you do. And, and I hope that we've been able to make this a little easier.
I also want to take the opportunity to thank Louise and May for the incredible depth of acquired wisdom and knowledge that they have presented tonight. It's really been a very important topic, and certainly bread and butter behind the scenes to a lot of presentations, and a great topic. So thank you to our speakers. I think there might be one more slide, which is about upcoming webinars. Thank you. So next week we also have another fantastic webinar coming up on observing your registrar, and this is also from a very experienced GP supervisor, Dr. Andy Morgan, who's from EVGP, and that will be a wonderful presentation, so you might want to tune into that. On the 24th of November, we also have part 3 of a webinar series on chronic disease management and health assessments, and these have been very interesting and well attended, the past 2, and this is the 3rd one in a series. You can come along to just this one. You don't have to have done part 1 and part 2. This third one is on time-based health assessments. So look forward to those. And in early December, there's another one on cultural and spiritual aspects of end of life. So that's also in the final webinar series for this year. GPSA is largely funded by the Australian government under the AGPT training program, and we thank them very much for that. And thank you to all of you who've listened and participated in the chat room. There's been a lot of really interesting discussions, so thank you very much. And we look forward to your feedback. So good night, sweet dreams to everyone.
Thank you, everyone. It's been a real joy to have such an interactive, and just thank you again for all that you do.